Hey, hi guys. I hope all of you are well, and great to see all of you who have joined these sessions. And welcome to these, last minute things which we have to do before we are going to give the exam. So it is nice. It is nice that you are all here. So, guys, let me tell you that it is extremely important that we, become a little smart when we are reading for this exam. Whether it's the INI-CET exam or it's the FMG exam which is coming, please try and understand that we are now in a phase where there are more and more people writing the same exam. And as always, things are getting tougher, and we are finding ways to trouble you. When we are writing the MCQ paper for you, we're finding ways to trouble you more than ever. But the outright basics never change. See, whenever we are making a paper for you people, so as a person who's been teaching all his life, and as a person who's teaching postgraduates in the institute where I'm working, and as a person who's been dealing with undergraduates also. So whenever we make a paper, we always think of the topics first. We don't think of new topics. The topics never change. So if you have that one concept in your mind, then you at least know what has to be read. You have 19 subjects, and 19 subjects which are, all of them are in fact, having their own intricacies, and the big subjects are endless, like surgery medicine, gynae, pediatrics, and preventive medicine, ortho, ENT. These kind of subjects will never finish, because these are subjects which are clinical, and clinical situations keep evolving. So when we have these evolving kind of subjects, how do you get to the idea of having a sense of completion to your preparation? So that's why I say always understand and that we have to get into the process of reading with the purpose of looking at an end point. The end point is reading the notes which you have made in this so many months of your preparation, and then having a set of MCQs which you're going to read. So, so that you don't miss the topics. So the topics are always going to come. So what we say, whichever book you have picked up, okay, fine. If you're Prepladder students, then I'm sure you have your notes already with you. Or if you're, Bhatia students, or your Marrow students, or your DBMs, DAM students, whatever students you are. This is advice to all my friends who are here. So whichever notes you have, don't get out of those notes now. Please revise your notes. Don't pick up new things now. And do me a favor, do not buy any new guidebooks just 1 month before the exam. This is where you're going to get really confused. So your notes first. So those MCQs you're going to read from one source, whether it is Prepladder or whether it is, let's say, your favorite MCQ book which you have picked up. Whichever book you have for MCQs, keep that book for seeing the MCQs, the topics which have come. Topics should not be missed. Whatever topics have come in the last few years, at least 3 to 4 years, those topics should not be missed. So read the notes, and all the topics which have come in the previous 3 to 4 years, those topics should not be missed. See, when I teach you the theory, I teach you around 90% of the theory. Yes, it's impossible to do whole of obs and gynae, everything together in a class or even in an app. Apps have more, classes have a little lesser. That's why we are wavering between 85 to 95% of the course when we're teaching you. But yes, there are some topics which rarely come the exams, and we can't teach you them in the classes. So what do? You are going to see those topics. There is an MCQ which has come on CA vulva. Now we do teach you CA vulva, but then the MCQs which have come, you will concentrate on them and not miss out on those. So that's why the guidebooks or the Prepladder MCQs, they are important, because at least you know the topics which have come. So you should have read those topics. Please have a sense of completion before you write your exams. I've always told this to all my PG students and my MCI students, that you will always get a sense of completion once you do your notes and you do the topics which have come in the last 3 years. So now that I'm going to be discussing about what we should do in obs and gynae, so let me tell you first what I feel are the topics you should not leave your rooms without. Let's see those topics, and then I'll also see there are a lot of MCQs which have come in your, a lot of sessions which have come in the chat. I'll see those also. So yes, when we're reading about obstetrics, in obstetrics, please don't leave your rooms without having read about the surveillance. Surveillance is something, if you've not read, then you're going to miss out. Surveillance, if you've not read, please, whatever you do in obstetrics, you read PH, you read IUGR, you read, diabetes, whatever you read, all these things which you've read, these don't make any sense if you don't know surveillance attached to these topics. The drug of choice for PH is levodopa, the drug of choice for diabetes is insulin, but you've not read antepartum fetal surveillance. How will you continue a pregnancy which is diagnosed as PH at 28 weeks? How will you continue the pregnancy till 37 weeks? For that to happen, you must have your basics very correct about the subject and should have read your surveillance topics. So antepartum surveillance and then intrapartum surveillance. If you have done that, only then you get into the understanding of how you manage obstetrics. Obstetrics is not just knowing the drug of choice for hypertension. Obstetrics is to know the drug of choice for hypertension and continuing that pregnancy till term and delivering it normally without having a fetal problem or a maternal problem. That is what is obstetrics. So obstetrics is complete only with the topic of surveillance. So do not leave without reading about NST or biophysical profile. Always a question comes on these questions, or Doppler of the uterine artery, umbilical artery. Please read about these and definitely go and read about the intrapartum surveillance, especially cardiotopography. And then in obstetrics, there is no way that you can leave without learning about ectopic pregnancies. A lot of MCQs come on them, and they are fond of asking you the management of ectopics when they come in special situations, like patient had an infertility treatment, has come to you with circulatory collapse, or a woman underwent a medical termination of pregnancy without doing an ultrasound, and now she had a circulatory collapse. So when a patient comes to you with this, you think in terms of ectopics. So that's why read the topic, read the MCQs, how the questions are coming on ectopics. Prenatal diagnosis, yes, there's no need of telling. Repeatedly have we been discussing about the screening for the aneuploidies, the dual markers and the triple markers, and all these, they're very important. The timing, if you know that there is a person who's got a triple marker positive, and that is a screening test. So you should know that triple marker is done at 16 weeks. So what is the test which is confirmatory for test which is coming at triple marker, that is 16 weeks. So if it is 16 weeks, then 16 to 18 weeks, you can do an amniocentesis, and you can do a cordocentesis after 18 weeks. So prenatal diagnosis is extremely important. You should know all the tests which are coming. Please read about non-invasive prenatal tests, and do have a read about pre-implantation genetic testing. So those are the prenatal tests which you must understand. And abortions, the reasons of abortions, spontaneous abortions, and how you go about managing abortions. These are often repeated MCQs. But yes, now that the timing of induced abortions have changed, so some questions are coming on even those. Till when we can do abortions, who can do abortions, and can only doctors do it? Can the others do it? The other systems of medicine, can they do it, which has not been approved so far in the country? So you must know these things also, and definitely understand the importance of reading the methods of doing second trimester abortions, because those are the ones in which they ask you about the ways of dilating the cervix. In the first trimester, the manual vacuum aspiration has been coming repeatedly, and I'm sure that part you're reading because it's repeated at least twice in the last 1 year, that question. So read about that. And one malpresentation, one malposition. MCI students, don't think that you won't be asked this. PG entrance students, you're definitely going to be asked about occipito-posterior. Please understand, occipito-posterior has been coming because occipito-posterior becomes occipito-anterior. It has been coming in all the exams. And occipito-posterior is a favorite with the INI-CET. And in FMG exam, they asked which kind of pelvis rotation is possible, which kind of pelvis rotation is not possible. That has come in the FMG exam. So both PG students and the MCI students, please don't take the advanced obstetrics as out of course type. That is not going to come in exam. This is just too much. And please, you should know something about the types of pelvis, if not in great details. Then you should know about rotation, and you should know about the common presentations, common malpresentations, common positions, common malpositions. These things do come. Common pelvic parameters, greatest pelvic dimensions, least pelvic dimensions, the inlet diameters and the mid pelvic diameters. These are things which will come. These are basics. So you cannot just say that, it is getting too much. It is too much, it is medicine. You're going to be a doctor and you're going to be a specialist now. So, we cannot just say that what is the shortcut to glory. There is no shortcut, but we are just telling you that what are the topics you cannot do without. So you must read about this when you go for the exam. And of course, PPH, read whatever you can. You must read your basic notes. And whenever you have time, go ahead and read for this topic, PPH alone. If you have an ebook or your friend has a book or you go to the library, read from Williams Obstetrics the topic once if you have time, because it's a little detailed there. But, these landmark topics, like suddenly they'll talk about preeclampsia. I'm showing the next slide. So these landmark topics, preeclampsia and PPH, they suddenly want to ask you more things. And since they cannot ask you from research papers, they'll ask you what is there in printed books. And the first printed book in obstetrics they look at is Williams. So these two topics, I feel, if you have time, go ahead and read PPH and PIH from Williams, and do make this extra bit of an effort. Of course, one question about antepartum hemorrhage will also come in the exam, whether it is plasma previa or it is abruption. This will also, even vasa previa they've been asking you, the app test they've been asking you. So I'm just trying to tell you the list of things which are, often asked of me when I'm going to, any class, any live class. Students will always ask me questions on these topics, and you have been asked about these topics in the exams. So this must be topics. Now we cannot ignore, like I'm telling you, PH. And recently they was asking about the SMS, like tyrosine kinase question they've asked. So you must know that in PG entrance they're asking you detailed stuff about PH and APH and PPH. I said, please go and read Williams once about these topics. And GDM and management, GDM and the first step of management is dieting, and then you must also think about the alternatives to insulin now that oral hypoglycemic agents are given. And previous cesarean is a favorite repeated topic. What kind of cesarean you can give a trial of labor, what kind of cesarean you cannot give a trial of labor, and what are the criteria to fulfill before you give a trial of normal vaginal delivery after a previous CS, and what are the signs of rupture of a patient who's been given a trial of labor. So all of these things, the previous LSCS is that one topic which will come. Sterilization surgeries, tubectomy, vasectomy, one question will come. They even asked you in PG entrance, they asked you about the Escher coil, which is again, since it's mentioned in Williams, it is not practical at all. I've never put a Escher coil. I've not seen it commercially also, let me tell you that. But I know it's there in Williams, so it can be asked. And it came in your exams. What is the Escher coil and how it is given? And, it's very cumbersome kind of a procedure to give the Escher coil. But they've asked you that question. So, they want to, PG students, the PG entrance students, they want to trouble them a little bit. They want you to read a little bit more than normal. MCS students, they want to trouble you with tough questions on the regular topics. So they are making it tough, like I told you. But then you can manage it by knowing at least the last 3-4 years MCQs. So at least that much you should do. And yes, there's always something about combined pills. Have a look on them. And RH incompatibility. Please, again, find time and go ahead and read all your notes on RH incompatibility. Any question you feel is too tough about RH incompatibility is one of my favorite topics. You can still write me an email at drprassan@yahoo.com. Always I say that, please write to me, because this is that one topic which a lot of you get confused and a lot of you ask me very interesting doubts in the classes. So you can still ask me on my email, or you can, those who are attached with me with Prepladder, please ask me. I have almost answered all the questions which were left on the forum, but I'm seeing them regularly. I'm making sure that all of you are able to understand whatever last minute things you need to ask me before the INI-CET exam or the FMG exam. So don't feel hesitant. Write to me on my email or write to me on the Prepladder forum, and these are two places where you can easily connect with. Okay, Instagram, there are too many things and too many media, ways to interact. Then we tend to miss out. So I'm just saying, limit to the email onto the Prepladder forum. So those who are not on the Prepladder forum can always write to me on the email which I sent, drprassan@yahoo.com. Now in gynae, please, I would say see endometrium, more questions come. than CA cervix. Of course, all of you know that CA cervix is the common cancer of women. The genital cancer which is most common in the country is CA cervix. It is that most common cause where a patient will have postmenopausal bleeding in the country. We know that. But CA endometrium, they're more fond of asking questions because etiology is more profound. Etiology is related to lifestyle, and of course, obese women having diabetes mellitus, hypertension, and association with family. There is so much of interesting information about CA endometrium. That's why they tend to ask you more questions on CA endometrium, although CA cervix is the common cancer. And yes, of course, there's an in thing about CA cervix is the vaccination and liquid-based cytology. So pap smear is good. Visual inspection of acetic acid is a good jugaad, like I always say that. It's a good method of assessing in the peripheries, since we can't take colposcopes all over the country and they're very expensive. So VIA is a good method of doing a cost-effective screening. But then yes, pap smear is the best method of screening. All that you know. But along with that, read about vaccination. There was one question about what is the number of serotypes which Gardasil 9 is taking care of. So yes, you know about that question very well. But then they're asking you whom to give that Gardasil and whom you give and how you can prevent, what are the number of doses. But then if you can't afford so much, can you give at least one injection to everybody at 9 to 14 years? Those are the SAGE guidelines. SAGE guidelines, which is not mentioned in many of the books. But then it's there. People are discussing about it. So something which is there, which is in discussion in the media, may become a question for PG entrance, not for FMG, but for PG entrance it becomes a question sometimes. Like the Robertson's classification of cesarean sections. So Robson's classification came. And now Robson's classification was never regularly discussed, but it's discussed in the postgraduate circles. We discuss about it, but for PG entrance we never discussed. So out of the blue one question will come. So we can't prepare ourselves for that. But then if it has come recently, read about that. That always you must do. What has come, you must read about that. And what is happening around you, read more, look at the newspapers, and if there is something about medicine which has come, so keep an eye on that. That's the best way. Those who are writing the PG entrance later in March, for them its best method is that whatever has been discussed in media, whatever is discussed in newspapers about medicine, like medicine as whole, surgery, medicine, gynecology, what is discussed new, please read about those topics also, because those are those off-the-book topics which come in the exams. Okay, so yes, read about the SAGE guidelines that you must give at least one injection. Personally speaking, I'm speaking on record, I'm not very satisfied with the vaccine because it's preventing only against 9 serotypes. I would want it to be a bigger range, but so far we say it is something better than nothing. You can give the vaccine if people can afford it. So on that method, we can say, okay, fine, something better than nothing. Yes, 9 to 14, if you give at least one injection, those are the SAGE guidelines. So that question came in the exams. And of course, Mullerian defects is a solid, repeated question about septate uterus, bicodate uterus, and they like to ask you whether MRI is better imaging, or the best method of doing the diagnosis is laparoscopy or hysteroscopy. All that they'll keep asking you about Mullerian defects, and which Mullerian defects can cause a patient to have infertility like septate uterus, and which Mullerian defects can have endometriosis. Most Mullerian defects will have some retrograde menstruation because of the passage problem. So they'll have retrograde menstruation and have endometriosis because of Mullerian defects associated. And then they'll ask you the synonyms. They'll not ask you Mullerian agenesis. They'll ask you about Mayer-Rokitansky-Kussmaul syndrome. So synonyms in gynae, okay? Whatever you're reading, whenever you're reading, which your favorite book you're reading. So suppose they've written abruptio placentae. In that bracket, they would have written accidental hemorrhage. So please don't forget to remember that, because we keep teaching you abruption all your life. When you're in the exams with us, when in the class with us, we keep teaching you about abruption. But that is what the Americans call it. The Britishers call it accidental hemorrhage. Now the examiners are a step ahead. We teach you abruption, and in the exams we ask you accidental hemorrhage. So we make it tougher by asking you synonyms sometimes. So some things you cannot help. We have habits of asking synonyms, especially in gynae a lot. So what is Gartner's cyst? Gartner's cyst is a remnant of the male duct in the female genitalia, and the male duct sometimes can leave a cystic swelling in the upper lateral vagina. But if we had just told you that the male duct, which is known as the mesonephric duct, is also known as the Gartner's duct, and the Gartner's duct remnant is known as the Gartner's cyst, it would have been much easier to remember, isn't it? But that part is not taught. We teach you mesonephric duct, we teach you Wolffian duct, but we don't teach you that it is also known as the Gartner's duct. So that's how synonyms will trouble you. So whenever you read something, if there is a synonym, please don't miss out on that. That may become a question sometimes. There was something about invasive mold once, around 4-5 years back, I remember in PG entrance, that what is the management of chorioadenoma destruens? And quite a lot of students missed out on that. But a few people who read the Robbins and in the Robbins, in the heading itself, chorioadenoma destruens, in the bracket they've written it is invasive mold. So you read invasive mold, all of us know that. But it is called chorioadenoma destruens, we didn't know that. So synonyms, they will trouble you sometimes. So do have a look on those. And of course, there are some topics like I already told you, C. vulva, it is not a very often repeated question, but it comes that once, just 4 exams, 5 exams, it just comes once and it gives you that heartache, oh yeah, I should have read about this. So C. vulva is that one topic in gynae-oncology because it is not a regular thing, but they give one question to trouble you. So might as well have a look. Staging, they are not asking you much, just the gross staging, stage 1, kya hai, stage 2, 3, 4, what is it involving that much? Not in great detail. But then they're asking you about what type of C. vulva you see, where do you see it mostly, which part of the vulva you see it mostly, and what is chemo given for C. vulva if there is palliation to be given. So there's some questions which are coming, not regularly, but that one question off the line comes to trouble you. Okay, so gynae topics which you must read, I've told you, but the ones which you should have read properly before you're revising, and that is the PCOS. And PCOS, one question about the treatment is going to come. They're going to ask you about clomidine citrate, they're going to ask you about letrozole, and they're going to ask you the pharmacology on that also. And pharmacology of letrozole, you must know because now that is the drug of choice. Clomidine citrate used to be till 2018. Now, both the drugs are important. MCI students, please understand that sometimes they use the old question bank and they might just say which is the drug of choice, and you may have to write clomidine citrate because letrozole might not be the choice because it has happened with 3 questions. Recently, they asked you a question that which is the drug of choice for PIH, and letrozole was not a choice. Methyldopa was the only reasonable choice there. So I have seen this happening in MCI exam. That's why I'm telling you that you should know that the regular drug of choice, of course, is now the letrozole, but before that it was clomidine citrate. Who knows if they use the old question bank, so you may be stuck with choices. So if letrozole is there in choice, go ahead and mark that. And do read about endometriosis. It's fairly common. 10% of women in the world have endometriosis. Fibroids, management. Etiology, they're not bothering you much. Management of fibroids, which you can do laparoscopically, which you can do with hysteroscopically. And male infertility, semen analysis. Recently, they updated the WHO recent manual. They've updated that. So I promised my students that I'll be sending you those values. So it'll be coming. Those who have come to me on the Prepladder forum, and those who have come to me on the classes. So on the Prepladder forum, I'll be giving you the latest values which have come. So some changes are there. Morphology has not changed. Morphology has not changed. So that is still 4%. So MCI students, they're going to ask you morphology because it's not changed. PG entrance students, so the latest 5th percentile values have been given. So I'll just share them on the forums wherever we can connect. So you can have a look before you go for the exam. And yes, pubertal changes are things which will you all keep reading. Please, I always say, delayed puberty in a girl is 13 and with secondary sexual characters it is 15. So don't keep asking me on the forum. Recently I was answering, in fact yesterday night, so why it is not 14 and 16? Because these are ancient values. Novak's Gynecology has changed these values 2 editions back. That's around 5-6 years back, it has become 13 and 15. So if some books are writing 14 and 16, I can't help it. Because when it comes to reference books, we have to go to Williams and we have to go to Novak's. Those are the, apart from going to Shaw's Gynecology and Holland Bruce Obstetrics, which are the basic books, and then Novak's and Williams are reference books. So we cannot do without them, okay? So these are the topics which I feel you must do in the subjects which we're discussing. Do the last 3 question papers. So those who are writing the MCI exam, do the MCI and the INI-CET at least. Those who are writing the INI-CET exam, do everything which has been done. The INI-CET exam students, they understand it very well, that they must do the last 3 years questions at least. If you can do 4 years, that's fine. PG entrance students, I would always advise you to do a good practice with the MCI exam questions also. They're asking some very tough questions there, and those questions, if you do a good revision, then your knowledge extends. So do have a look on the NEET papers also, and all of them is there freely available on the YouTube. If you have done some training with me, you can see me giving you all these answers for the last 3 to 4 years. You just put my name and on the YouTube, just put my name and write INI-CET 2022 May June exam or INI-CET 21 November exam. You just write my name and you'll get me discussing the questions of Obs and Gynae which have come. So, you don't have to join any forum. You don't have to join my channel. No, please don't. I'll never request you to do that. Just put my name and you'll see it for free. So go ahead and do the MCQs with the teachers you like. Whichever subject. You must have done your training with one teacher for one subject. I'm sure you must have done that. So whichever teacher you like, all the teachers who are teaching in various forums are there on the YouTube with solving all the MCQs which have come in the recent few years. So whichever teacher you like, at least do that teacher's MCQs. So like I said in the beginning of the sessions, that when you want to have a sense of completion, for that sense of completion, you have to do the questions which have come and the notes which you have. So do the last 3 years, 4 years MCQs with the teachers who have taught you. All right, that's one very good method. And I will always say that, okay, before I say that, let me see. There's a lot of chat which has happened. So let me see what you guys have been saying. Give me a moment. Hi, hello. Good afternoon. And session might be today. Okay. I'm live, guys. So you can ask me something. Okay, people are worried about the match also. All the best for the match. That's why I thought we should do it at 12 o'clock and not afternoon 5 o'clock. The time was given to me. I said 5 o'clock koi nahi aayega because there's a match and they're going to miss this. Thanks. Hi, Vivek, Praveen, Sneh, Fazil, Shakir, Rali. Very nice. Hello, everybody. And right. KF Kitchen, that's an interesting name. Great. Hi, Rafiq, Mohammed, and so they are mostly greetings. Thanks. I can't speak in English because in English that like people say, because some of my South Indian friends are here and they want me to speak in Tamil. But no Tamil, no Punjabi, no Hindi. So the medium has to be something which everybody understands. So that's why. You're having fun with me, Dhananjay, that you must give English explanations. Thanks for all your remarks, guys. And I'm not getting any questions, at least few topics, if you get fit. You want to discuss something, Nikhil, you can ask me. You want some something, you can ask me some question, no problem. I'm here for some time. Indian version of Gardasil, we don't think of that. I mean, people, I would want majority of the serotypes to be taken care of. Problem is that only 9 serotypes. Why? Since I told you that I'm not very fond of this vaccine. Why? Because when Cervarix came, it had only 2 serotypes taken care of. When Gardasil 4 came, it had only 4. So that means they were not good then, isn't it? Because they now came with Gardasil 9. Because 9 is better than 4. Now soon they should be coming with Gardasil 25. So till they cover all the serotypes, I'm not very comfortable with this because CA cervix is such a common problem in a country. So if you're giving a vaccination, it should be taking care of CA cervix completely. So the problem with CA cervix is that if you give Gardasil, it is going to prevent CA cervix. 90% is going to prevent against the 9 serotypes only, not CA cervix by all the serotypes. Against the 9 serotypes, there is a 90% protection if it is taken before the first exposure. If it is taken after the first exposure, that is after sex has started, then it is only 40% prevention. So that's why I say that I'm not very fond of this vaccine. I mean, I can't go against it because it is something better than nothing. And especially young girls, 9 to 14 years, if you give this, then that's a good prevention for those girls at least. but then I would want this vaccine to be better. And so there are no questions. Okay, they're asking me some questions, so I'll ask. Dr. Ray has asked me, when is cerclage done? Cerclage is done around 11 to 14 weeks. That's the time when we know that the placenta has totally taken over. So when the placenta has totally taken over, that's the time when cerclage should be done, because we are sure that this placenta will continue the pregnancy. So generally the time is that. So I generally teach in the class that after 12 weeks you should do, because that's the time when placenta is completely taken over. Of course, luteoplasmal shift, that question is 6 weeks. 6 weeks, the luteoplasmal shift happens. Corpus luteum gives away its function and placenta takes over. But the completion of that taking over is at 12 weeks. So don't miss out on that. Okay? And when should you remove the cerclage? Some cerclage you can remove, like you can remove the McDonald's cerclage, you can remove the worm cerclage, you can remove it. When should you remove it? Just before the patient is going into labor. Let's say around 37 weeks, you should do that. But you should not think of removing cerclages like the Shirodkar cerclage. Shirodkar cerclage is the one in which we push the bladder up and then put the stitch. So when you push the bladder up and then put the stitch stays in situ. It stays forever. So you cannot do a normal delivery, you have to do a cesarean. Similarly, in PG entrance, they asked you about Benson and Durfee and Lash and Lash. They asked you these cerclages which are put before a patient is pregnant. So which are the prenatal cerclages? Lash and Lash and Benson and Durfee. They're actually known as the cervico-ischemic cerclages. So yes, certainly like I tell you now that one question they're going to ask you away from the routine. So what are the prenatal cerclages, which generally we don't teach you in detail, but that came once in the NEET exam, just the recent one. Okay. Induced abortions, why ultrasound is not important. I don't know why you're saying that. See, ultrasound is important always. You must always confirm your diagnosis that when you're inducing an abortion, ultrasound should tell you the location of the fetus. A lot of MTPs are done when patients are just taking the tablets for getting an MTP done without knowing that the pregnancy is in the uterus or in the tube. So every day, the place where I'm working and where I'm discussing this session from, every week we see 1 or 2 patients who have taken MTP tablets without getting an ultrasound done, and the baby is actually in the tube and they've come with a circulatory collapse. They've come and shocked to us. So never think that patients will not have an ultrasound get an MTP done. That's not a good habit. In today's world, do an ultrasound before you do an MTP. Always do that. MTP, especially for terminating a pregnancy of a lady who wants a willful termination of a pregnancy. Please definitely do an ultrasound. Dr. Lulu, hi, thank you. Hi from Hyderabad. Is rapid revision enough? Now, rapid revision is that one book which I always say that if you have been a little late in your preparations and you have not picked up any book so far, so reading rapid revision will be a little difficult. I always say that. So those who are picking up the books last month, then just do the MCQs for the last 5 years. For you, 5 years MCQs, because it's going to increase your knowledge very fast. Those who have done the preparation well, for them rapid revision is a good way of finishing off things. But you should have done, if you're doing rapid revision with me, you should have read with me before. So whichever forum you met me. So if you do a rapid revision with me and you've done the class with somebody else, then you're going to be mighty confused. So rapid revision is a good way to quickly revise things, but be smart in that. Do rapid revision of Dr. Vij if you read with Dr. Vij before. If you have never read, then also rapid revision will help you. But if you read with some other teacher and now you're doing rapid revision with me, you'll get confused. So be careful about rapid revision. Rapid revision is very good revision for those who have already done preparations with the teacher whose rapid revision you're doing. Remember that way, okay? Rohit, hi. And so CA cervix we discussed a little bit. And I am exporting. Hi. எப்படி இருக்காங்கப்பா எல்லாரும்? சௌக்கியமா? Good. Punjabi bolo, right? Seni Saab. Seni Saab, I hope all is well with you. ਕਿੱਦਾਂ ਜੀ? ਵਧੀਆ? ਪੜ੍ਹਨ ਡਏ ਹੋ ਕੀ ਕਰਨ ਡਏ ਹੋ ਹੁਣ? ਅੱਜ ਤਾਂ ਮੈਚ ਵੇਖਣਾ। ਰਾਤੀ ਬਹਿ ਕੇ ਪੜ੍ਹੀ, ਰਾਤੀ 8 ਵਜੇ ਤੋਂ ਲੈ ਕੇ ਸਵੇਰੇ 6 ਵਜੇ ਤੱਕ ਬਹਿ ਕੇ ਪੜ੍ਹਨਾ ਤੂੰ, ਠੀਕ ਹੈ? ਸੈਣੀ? FMG, Mullerian anomalies, please. Discuss RH incompatibility. That is a. I was told that I have a session for half an hour. I can take it for 5 hours if you want, but then you're going to run away for the match. So I know that RH incompatibility is something you must, if you have the app, please go ahead and read. I think there is some part of my app is free. Just look, those who have not read RH incompatibility, and just check, just download the app. You can put my name on Google Store and you can download the app. And in some 30% of the lectures are free. So those who have not bought the app, I'm not saying please buy the app. The free lectures that you can do, or you put my name and see if there's a YouTube free lecture on RH. I don't think so. The free lecture is there, not there on RH in YouTube, but I think on the app, there are 30% free lectures. So just see if RH incompatibility is there. Or you can send me queries. Read about that. Send me queries on. These days, I have the time to. I'm trying to make sure that all the questions, all the queries which are there on the Prepladder forum or on an email, I'm trying to finish them off. So we will take care if you have some questions. Okay. CA endometrium and CA cervix. Please, these two, and I'm even saying CA breast. So these 3 cancers in women, please don't leave your rooms without reading them. These stagings you should know in and out. These cancers you should know in and out. CA endometrium treatment, they don't ask you much. CA endometrium, they generally bother you about the etiology and the staging and hyperplasia. MCI students, my friends, please, hyperplasia of the endometrium, what is the management? So hyperplasia is precancerous. It is not a cancer. So precancerous lesions, what you can do, and of course cancer, what you do is different. So precancerous lesions without atypia, you can give progesterone. With atypia, you will have to do hysterectomy again because the age group is beyond 40 years mostly when there is hyperplasia. So without atypia, progesterone, and with atypia, you can do a hysterectomy in hyperplasias. So Samarth has asked a good question that if they don't say the country which is involved, you have to write about India. I don't know, Samarth, whether you're a PG entrance student or you're an NCI student, but please understand, when we're asking you in an exam in India, we are asking you always Indian data. So if I don't specify the country, why will you answer what is happening in central London, or happening in Ireland, or what's happening in Boston? We are not going to ask you what's happening in Canada. We're going to ask you what's happening in India. So if I don't specify, why do you even have a doubt? I mean, I know there are so many teachers who are confusing you with this information, but please understand, if we don't specify, if I'm asking you what is the most common heart disease in pregnancy, it is rheumatic heart disease. Now, in the books, Williams Obstetrics clearly writes it is congenital heart disease. I'm going to ignore that. Williams is an excellent book. That's my Bible. But I'm going to ignore that part because it's an American book, and congenital heart disease present in pregnancy for women who are pregnant in USA. In my country, rheumatic heart disease and rheumatic fever is so common, and rheumatic heart disease is so common. I'm not going to say. So if I ask you what is the most common cardiac lesion of a pregnant mother, so you're going to say what? You're going to say rheumatic heart disease, mitral stenosis. You're not going to say congenital heart disease. You have a doubt in that. So if I don't ask India, you have to write India. I mean, like you're writing an Indian entrance exam, you're going to be a PG in India. We are not going to ask you the world incidence, because if I ask you any instance, it's Indian. And one very important basic, what's the difference between India and the world? I mean, like, what kind of people are there in majority in the whole world? That's where it all finishes. If you go out of India, you reach China, and China and India is 55% of the world population. So yes, 55% of people are India and China. What happens to us is the commonest thing happening in the world if they ask you like that. And then whole of Africa is like this, whole of South America is like this. So underdeveloped and developing. These are the two types of countries which are the commonest in the world. Developed part of the world, I think your PSM people teach you, is only 15 to 20%. 80% of the world is like people like you and me. So if they ask you India, write India. Even if they don't mention India, outside India, 80% of the world is like us. So why this confusion is happening every time? So good you asked me here. So these are the things we should discuss here rather than discussing whole of Obs and Gynae again. These are the things which we should be discussing. So guys, come on, don't get confused in that. When we don't say India, we mean India. Obviously, we're writing an Indian exam. Okay? Cost-effective method, yes. Cost-effective method of a lot of you have asked me this question. Yes, I would always say Pap smear is the best method. Now, what has happened? Shaw's book of gynecology has mentioned that it is a cost-effective method. And I was speaking with Dr. Vivek, and he told me that it's even mentioned in the PSM books. So when it is mentioned in two major books, I cannot refute it much. Although I'm not happy with that answer because visual inspection of acetic acid has to be done by a gynecologist, and the biopsy has to be interpreted by a cytopathologist. And these two kind of people can't be there all over the country in all the villages. So it's not practical. It's a good trial which is going on in Maharashtra, we know that. But then is it the best method across the country? That's very debatable. I've discussed with all my friends who are in the major institutes in the country. But then since it is mentioned in Shaw's and it's mentioned in the Park book, I'm not going to refute it. So if they say cost-effective method, go ahead. I'm willing to change my answer to visual inspection of acetic acid. Yes, I'm saying it online, but the best method, if they ask you, it is always Pap smear. For the time, it is Pap smear as the best method. If they ask you cost-effective, since it's mentioned in two major books, and those two books are the reference books, go ahead and write visual inspection of acetic acid. All right? So indomethacin, if it is given regularly for a long time, will cause oligohydramnios, and oligohydramnios can cause pulmonary hyperplasia as a secondary problem. But then indomethacin is never given for such a long time. But what indomethacin can do, if you give it beyond 32 weeks, suppose a person has preterm labor and you're giving indomethacin, and it is beyond 32 weeks, suppose 34 weeks for preterm labor and you're giving indomethacin. So it can cause premature closure of the ductus. That is a more common question which is going to come. So yes, indomethacin, if you give it for for whatever purpose, it is going to cause the reduction of the urine output of the fetus, and we give it for polyhydramnios. But if you give it for any other purpose, you give indomethacin, and if it is given continuously without looking at the volume, so baby can have less urine output, and then have mother will have oligoamnios, and oligoamnios can cause pulmonary hyperplasia. So that's a problem of oligoamnios, that a pulmonary hyperplasia happens. Menopause topic, I don't know what you want to ask me, Ashish. You must ask me a specific question because all of Obs and Gynae, and we are discussing what to read before the exams. So if you have a doubt about menopause, you can ask me because HRT is my favorite topic. I love teaching HRT always. And after 60, the drug of choice for a woman having osteoporosis is bisphosphonates, and we know that. And that question came in INI-CET exam. It cleared a lot of controversy because yes, I always say the drug of choice for osteoporosis, even when we say 50 years to 60 years, I would say it is estrogen, and after 60 it is bisphosphonates. But yes, I know some other teachers are they're having good sources to back up their answer that bisphosphonates is the drug of choice. Remember, bisphosphonates is the drug of choice after 60 years. Before 60 years, there has to be some other drug. That's why they asked you this question in AIMS exam. The INI-CET 21 November exam, you please see the question, what is the drug of choice after 60 years, they've asked. So if they ask you after 60 years, then that is bisphosphonates. I'm saying that. Everybody is saying that. So that also means that it is not bisphosphonates before 60 years. Simple logic. All right. So go ahead and read your Shaw's. It is written clearly in one page in the front and the same page on the back. They've written it 3 times that it is the best drug after 60 years. Before that, it is HRT. So yes, of course, you can show me so many other sources which say that bisphosphonate is better. But since it's mostly a gynae question, and they're asking a question based on after 60 and before 60, which is mentioned in Shaw's like that, See, I changed my question to VIA, isn't it? Because it is mentioned in shorts. Those are your reference books. So if I'm willing to change, you should be willing to change a little. So, okay, so after 16, it is Bill's phosphonates. Before that, please stick with hormone replacement therapy. All right, for best for osteoporosis. Stress urinary incontinence, Kundan, please read about that. It is associated with prolapse, and we always tell you that stress urinary incontinence is treated with a stitch under the bladder neck, which is known as a Kelly stitch. So please, you must read about that. Stress urinary incontinence. Urinary incontinence is a good medicine topic. Stress urinary incontinence comes to my specialty because we have prolapse. So please do read about incontinence as such. It is part of your, you don't think that it's too much, okay? Nothing is too much. If it has come in the exam, it is your headache. You must read about that. MCI students, how to prepare? It's a little late for asking you that. Your exam is in the next 15 days, 20 days. So I think you must now quickly revise all the questions if you've not started so far. If you've read already, then revise with rapid revision. If you've not read at all, then last 5 years, INI-CET and MCI papers, my subject, go ahead and put my name and see the MCQs on YouTube. That's a very good preparation if you've not read so far. At least you know all the questions which have come recently. You are a good chance of getting 50% marks with that alone. Good chance. Pap smear, can it detect trichomonas vaginalis? Yes, Nikhil, why not? Because what we do for the diagnosis of trichomonas vaginalis, we take a swab, we put it on the cervix, take the swab, with a wet swab, we take the discharge from the cervix or from the vagina, put it on a slide and look under a microscope. So when I'm doing a pap smear with the spatula, the same thing can come under the slide again. Yes, it can diagnose. Why not? Misoprostol dose. For what do you want to know? Misoprostol is given around 200 micrograms orally for PPH, 800 micrograms vaginally for PPH, and 800 micrograms rectally, rather, I said vaginally, that's wrong. 800 micrograms rectally for PPH, and if you want to give it for abortions, 800 micrograms vaginally there. Then you get vaginally for doing the abortion. Those who are reading for FMG 2023, there's a long time to prepare. Please give 6 months of hard reading. Please do all the topics which have come in the exams recently. And the best way, if you're Prepladder students, please do the app completely. You have enough time if you're writing 2023 exam. You have enough time. Do the app completely or do the notes of Dr. Vij completely in any forum you met me, and then do the MCQs. Please go ahead. There's no shortcut. Please read. Get a proper MCI students. This is the first time you're reading so intensively because yes, interns also from India also read first time so intensely for PG entrance exam. But the teaching is the same. You know how we've been teaching you in the MBBS is the same teaching which is more intensively read when you're reading for PG entrance exam. But for MCI students, it's a total shift of method of teaching, shift of the topics which we are discussing. Total methodology changes when you come to this country and read for the MCI exam. So give yourself 6 months of hard reading. All right. So yes, please do the app completely or do the notes completely, whichever forum you can see. Okay. Hepatic disorders, please read about high bile acids and bile salts cause itching and bile acids more than 40 that they can be detrimental to the pregnancy. Hepatitis in pregnancy, do read about that and definitely have a look about cholestasis in pregnancy. There are common things which come in the exams. Definitely, there was a question in PG entrance about fatty liver, and that comes around late pregnancy, 35, 36, 37, and that's why you must read about that. Also, it doesn't increase the enzymes too much, it doesn't increase the bilirubin too much, but it can be even fatal if it is not controlled well. So read about fatty liver of pregnancy. Gravida is a state of being pregnant, Dhananjay. Gravida is a state of being pregnant. So till a woman is not pregnant, don't put a G. Suppose a old lady has 3 children. So you call her 3 live children. She would have delivered thrice. So para 3 live 3. Don't say she's gravida 3, para 3, life 3. She's 65, she cannot be pregnant. Suppose the woman is 25 and she has 2 children. Today she is pregnant? No, she's not pregnant. So she is also para 2, life 2. She is not gravida 2, para 2, life 2. Okay? Please don't put a gravida till the lady is pregnant. That's one mistake everybody does. And always go from back. GPLA system is asked. GTPLA system is not asked. I've never seen it in the exams in the last 3 years, so definitely not. So GPLA system, and always go write the abortion first, then the life, then the para, and then do the gravida. If you write like that, you'll not be confused. Okay. Meek syndrome, Ankit, that's a very basic question. Please read about Meek. Meek is fibroma of the ovary with ascites and pleural effusion. This is the very common MCA question. It has come in the June 4th exam, which came for you 2020 exam. So Meek and Krukenberg syndrome in ovarian tumors. Meek and Krukenberg to definitely pata hona chahiye. Krukenberg is secondary to the ovary, and Meek is fibroma of the ovary with ascites and pleural effusion. Krukenberg is secondary to the ovary, mostly from CA stomach. Flow with drug of choice of PCOD. If you've said that, that means you have to go ahead and quickly. There is the PCOS lecture on my name, free on YouTube. Put my name, read PCOS. Today, if you ask me drug of choice of PCOD, that means you've not done my class, because there is no drug of choice of PCOD. There is no drug of choice for endometriosis. These are syndromes. What part of PCOD you ask me? You ask me about hirsutism. You ask me about anovulation. You ask me about irregular cycles. I can tell you drugs for that. So there is no one drug for PCOD. ऐसा अगर आपकी guidebooks में लिखा है, so that is wrong. If it is written like that, drug of choice for PCOD is this. There's nothing like that. Drug of choice for ovulation induction, that is letrozole. I've already mentioned in this discussions. Hi, love from Gautam Nagar. Right, that's where I live, man. Gautam Nagar is like home for me. 4 o'clock to morning, 12 o'clock or 2 o'clock sometimes. Chandan Gowda, hi. Right, I think mostly the same thing. So depression in this last stage. So Yatin Kandewal, that is one question which I wanted to say. Let me see the other questions. Depression. Most topics of FMG are the same topics which I discussed with you. Topics are the same. FMG, MCI, please don't get confused. The topics are very much the same. If you're any student, the topics are the ones which I discussed. Same topics. Don't think MCI is a milder exam. MCI questions are more standard. PG entrance questions are a little wide. They ask you the same topics in more depth, and they ask you many things which are not regularly asked in exams and might not be in the books also sometimes, PG entrance. But MCI students, the topics are constant, and you should know all the topics which I told you. No escape from that. Okay, there's no, you can't just read 50% of gynae and hope that you get, 100% marks in the exams. So please don't do that. Yeah, ex-recorder has mentioned very well about 13 and 15, and Ajaydeep Singh 600, 800. Okay, correct. And somebody's saying, Alvin, meconium aspiration, how can it happen intrauterine? See, what is happening in meconium aspiration? Baby is not breathing inside the mother. When the baby is inside the mother, baby is breathing from the umbilical artery and the umbilical vein. So the circulation is that way. But what is happening? The baby is swallowing fluids, obviously. That fluid goes into the lungs to expand the lungs. And the baby is also swallowing that fluid which is going into the stomach. So baby does not have any reflexes to prevent fluid from going into the lung. So that fluid, the amniotic fluid which is going to the lung, is expanding the lung and helping the lung grow and helping the chest also grow. So it's a very important thing that the baby swallows fluid while the baby is inside the uterus. So baby swallows fluids, those fluids go into the stomach and to the lung, importantly, for the lung to expand. Now, once we are born, we have to start breathing from our respiratory tract. So then no fluid should go inside. So then, of course, we don't take fluids to our lungs after we are born. Before that, the fluid always keeps going to the lung to expand the lung. Now, if the baby is past stools, which is meconium, while the baby is inside the uterus, that will make the whole liquor full of meconium, and meconium will also get into the baby's lung when he swallows the fluids. So that meconium is irritant to the lung. So that is what is the meconium aspiration syndrome. Can happen. Yes, can happen. Baby will swallow the fluids of the amniotic fluid is swallowed when the baby is inside the uterus, and if it has meconium, that will also go into the lung. That's why the babies don't do too well when they have meconium aspiration syndrome. Yes. See, if first twin is breech, it is known as a complicated breech. Breech does deliver normally, but if it is a twin with the first breech, any breech with anything else, breech with previous years, breech with the first breech, twins with the first baby as breech. This is complicated breech. So complicated breech, we have to do a cesarean. Twins with first breech, go ahead and do a cesarean. Okay? Of course, we've always done that normal, but then that is not for you. First baby breech in twins, go ahead and write cesarean section. First line man Arjun Vyas for abnormal uterine bleeding. Is it tranexamic acid or NSAID? If both the choices are given, go ahead and mark NSAIDs. If both the choices are given, NSAIDs is even before then tranexamic acid. Both are first line drugs anyway. All right, so somebody is saying when the questions come. So I'm sure that I've discussed a lot of questions and a lot of topics which have come in the exams. And this session is not a revision session. This was a session to tell you important topics, a lot of important MCQs I've told you. And the session is to tell you how to deal with an exam. So the most important part of the session is what I'm going to say now, that there is a lot of nervousness before the exam. There's a lot of you who will get depressed because some of you are writing the MCA exam for the second time or even the third time. Some of you writing the PG entrance the second time or the third time. Those who are writing for the first time are nervous. So if you're not nervous, then you're not students, then you're gods. If you're not nervous, if you're not unsure, then how can you be called a student? There is not one student who will come and tell me that I know everything before the exams. Every student says that whatever I've read is getting out of my head. I'm not able to retain it at all. Some girls will come and tell me, sir, whatever I know that I'm confident that I'm going to mark the wrong answer tomorrow. Some get so worked up. Some boys will say, sir, I'm ultra cool. I know everything. I'll manage. Those guys are actually very nervous, and that's the exterior they have. So all of you go through these phases before the exam, that some of you are very nervous, some of you are very laid back, and some of you are getting to bite off all the nails on your fingers. Please, it's normal. If you're not nervous, then you won't read. But then don't get into the extremes of nervousness and don't get into the extremes of being laid back. Being super confident and being super nervous, that is detrimental. Being the right amount of nervous, getting tense before going for the exam, not able to sleep properly 1 week before 2 weeks before the exam, getting angry with your relatives, with your friends, and with your loved ones, with your brothers, sisters, having frequent quarrels with the people around you can happen. These are normal things because you are worked up, you're focused, and people, when they talk to you, they distract you from your focus. So yes, these are extremely normal. These are absolutely normal things which keep happening to everybody, and I've gone through them. Even before this session, I had the butterflies. I was doing some work in the operation theater, and then I had some butterflies in my stomach. That what I'm going to do and talk to the students. But then, any stage, is a reason for being a little nervous. So nervousness helps you prepare better. I always say that if you're too laid back, then you're going to do very average in your life. If you're too laid back, so be a little nervous, be a little worked up. I will never say, cool raho yaar, mast raho yaar, exam thand mein jaake likho yaar. If I've ever said that, then it is wrong. Always be a little worked up, always be a little concerned. Yes, if you're nervous, you'll read better. So stay cool, stay positive. It's easy to say that. Stay positive. That's very easy for me to say. Please think if you're not reading, you will fail. Keep that in your mind. Okay? So please be a little nervous. Please be a little worked up. It pushes you to revise better, but don't get into the extremes. Just remember that the amount you are nervous, your neighbor is maybe a little bit more than that. So everybody is going through this nerves. It's going at that time when people are going through butterflies in the stomach, cramps. Some of us increase the bowel frequency. Some of us get totally constipated. All these things are normal. Okay, so don't feel that you are alone getting nervous. Everybody around you is getting nervous. Yeah, there are those 1% of students who know all the answers, who are well prepared, and they're not probably listening to me in this session. They're going to pass. They're going to get the PG seat which they want. They're going to get radiology. I know that also. So please, those people are 1%. 1% is there in every class. You know about them. You know the names of those people when I'm discussing that with you. So that 1%, fine, forget about them. 99% of people are like you and me, who get nervous, who get worked up, and are very tense before the exam. So yes, we understand that it is a life which is not at stake. Life shall go on, whatever happens, but give your best effort. That is what I want to say. We will have a medical degree if we are MCI students, and we will have a PG if we are writing the PG entrance. That will happen. Eventually, it will happen. The journey might take a little long. So 10 years from now, you will be a surgeon, and your friend might be a surgeon a little maybe a year before you. But both of you will be surgeons, and you will look back at these 10 years and say, "Yaar, us time hum log kitne tense the, unnecessarily we're getting worked out." So please think about your life, which is going to be 10 years, 15 years from now. This is the journey you have to go through. You have to go through this nervous moments. You have to go through this time of uncertainty and insecurity, of asking money from your parents and getting, into these quarrels with your relatives all the time, and not helping in the house at all and doing only your own thing. Yes, it is part of it. So don't get depressed. Get worked up. Get focused. Think only about the exam. Last 1 month, which you have those people writing for the MCA exam, you have this 15-20 days. Now, just think of your reading, revising. Don't pick up new books. Just revise the 19 notes which you have from the 19 teachers, and if you have time, revise the 19 set of MCQs of MCI at least. And those who are writing the PG entrance exams, please, this is the time when you have nothing else to think but about your books. Give that 45 minutes of impetus, that thrust of reading for 45 minutes. Give that intense 45 minutes. In that 45 minutes, don't get up from your chair. Don't talk to anybody. Know what's happening. No music. You have a very warm room. If you don't have an AC, it doesn't matter. Sweat it out. If it is very cold, don't get up to buy get a new sweater, or get a, all should have been done before you stand up. Now, once you sit down for your 45 minutes, no distractions. Your parents are calling you. I'm not coming my 45 minutes. Virat Kohli is scoring a century. No, not my 45 minutes. So that 45 minutes, read so hard, then get up and take a 15-minute break and assimilate. Discuss with your friend who's reading with you, and then give another 45 minutes. Give these bursts of 45 minutes around 6-7 times in a day. That's more than enough reading, rather than sitting on the table for 8 hours, 10 hours, and in that you're reading less than 2 hours effectively. So give this burst of 45 minutes, and that 45 minutes, do not look left or right. Okay, stay focused. Look at your goal. Your goal is to write the MCI exam and pass. Your goal is to get the PG entrance going and get your best seat possible. So if you have your goal in mind, then distractions don't distract you. There will be distractions of people who get easily distracted. Even food is a distraction. Even a good song somebody's playing on the stereo in your neighborhood, that becomes a distraction. So if you're easily distracted, then nothing will help you concentrate. So if you're getting easily distracted, then cure that very fast. All right. So right amount of nervousness will always push you to read better. Okay. So one last look at things which are coming. Good. Right, guys. I hope all of you do well, and best wishes for exams. And anything else, please meet me on the forum of Prepladder or on drprassan@yahoo.com. I'll be happiest to discuss with you whatever is required. Okay. So God bless you. Do very well, and write me on the email and tell me that all of you got what you wanted in your life. All right. Ciao. God bless you. Bye bye.